Chapter 17 Reproductive and Perineum. The female reproductive system. At its A and P, it's comprised of many different parts. The external genitalia, referred to as the vulva, includes everything from the mons pubis, labia majora, labia minora, the clitoris, the vaginal vestibule, ducts of the Skene's and Bartholin's glands, vaginal orifice, urethral meatus, and perineum, just to name a few. The mons pubis is the adipose tissue covered with hair, while the labia majora are the tissue folds that extend downwards from the mons and surround the vestibule while meeting at the perineum. On the other hand, the labia minora lies inside of the majora. These are darker, smooth, hairless folds divided into medial and lateral aspects. Continuing with the external genitalia, the clitoris is a small cylindrical bud of erectile tissue that is the primary center of sexual stimulation, while the vestibule lies between the labia minora and contains everything from the urethral meatus to the hymenal tissue and Bartholin's and Skene's glands. The perineal surface is a triangular shaped area between the vaginal opening and the anus. The pelvic floor there consists of muscles forming a suspended sling that supports the pelvic contents. Here we just have a diagram demonstrating the external genitalia. Everything from the mons pubis to the labia majora, labia minora, and hymen folds, hymen tags. Moving on to the internal structures and organs, the vagina is smooth muscle lined, with mucous membrane extending posteriorly from vestibule to uterus. The posterior incline, approximately 45 degrees to plane of body. The uterine cervix contains superiorly and anteriorly into the vaginal cavity to form a recess or fornix around the cervix. Going deeper onto the uterus, this is a hollow, thick, pear-shaped muscular organ, suspended and stabilized loosely by four ligaments between the bladder and rectum, while the cervix, the mucus-producing gland, is the lowest portion of the uterus. It is an opening, the small, round, in a nulliparous woman as it sits irregular slit in a parous woman. The corpus is a portion of uterus above the cervix, composed of three sections. The isthmus, which is a narrow neck from which the cervix extends into the vagina, the main body of the uterus, and the fundus, a bulbous top portion of the uterus. This will be especially important as you move on to your OB modules. The ovaries appear connected to the uterine body by ovarian ligaments. The primary function of ovaries are ovulation and secretion of reproductive hormones. In ovulation, this is the release of an ovum or egg, which usually occurs on a monthly basis as part of the menstrual cycle. Here we have a diagram demonstrating those internal structures. And here we have another diagram just showing that endocervix, the external os, and the ectocervix. Moving on to the menstrual cycle. This is hormonally driven. It begins in the hypothalamus, anterior pituitary, and ovaries together that regulate a 28-day cycle. In the first stage, days 1 to 4, or the beginning phase, estrogen and progesterone levels decrease, triggering a shedding of upper layers of the endometrium and menstrual bleeding. On stage 2, or days 5 to 12, postmenstrual or pre-ovulatory phase, follicle stimulating hormone, FSH, stimulates follicular growth and ovary and maturing follicle production, producing estrogen, which supports egg development. In stage 3, or days 13 or 14, this is ovulation, characterized by a steep rise in estrogen and luteinizing hormone. The egg is expelled from the follicle and drawn into the fallopian tube by fimbriae and cilia. This also has a subsequent rise in progesterone that causes thickening in the uterine wall. Further on to stage 4, in days 15 to 20, this is the secretory phase. After ovulation, follicle stimulating hormone and luteinizing hormone decline. The egg moves into the uterus and the follicle becomes a corpus. Progesterone rises and predominates as the uterine wall thickens in anticipation of receiving the egg. In stage 5, or days 21 to 28, this is the premenstrual phase. If fertilization of egg and subsequent implantation does not occur, the corpus luteum degenerates and the progesterone production decreases. The estrogen levels begin to rise again as a new follicle develops. Here we've got a graph just showing the different cycles, everything from the gonadotropin cycle, ovarian cycle, sex hormone cycle, menstrual cycle, and the temperature cycle. And finally, menopause. Women undergo a period of decreased hormonal function starting between ages 35 and 40 years. Termed climacteric, it is a long transition phase extending many years and includes endocrine, somatic, and psychologic changes involving a complex relationship between ovarian and hypothalamic pituitary factors. Menopause is defined as a permanent cessation of menses and is considered complete after women experience an entire year with no menses. Ovulation usually ceases 1 to 2 years before menopause. This is the age that women reach menopause, can vary greatly, but mean is 50 years. Moving on to the male reproductive system, this can be categorized into both internal structures and external genitalia as well. Though much more simple, the internal structures consist of the testes, ducts, and glands, while the external genitalia are comprised of the scrotum and penis. The testes are the paired sex organs located within the scrotum, oval shaped with a smooth surface and rubbery texture. The primary function of testes is the production of sperm, with each testicle containing a series of coiled ducts or seminiferous tubules where spermatogenesis occurs. As sperm cells are produced, they move towards the center testes, traveling into efferent tubules. The ducts are then responsible for the transportation of sperm. The sperm travel from the epididymides to the vas deferens to the ejaculatory duct and out the urethra. Sperm move into comma-shaped epididymis, a long coiled duct lying in the posterior lateral surface of each testis. The vas deferens, also known as the ductus deferens, transport sperm from the epididymis to the ejaculatory duct. Enclosed within the spermatic cord with arteries, veins, and nerves, it ascends through the inguinal canal. The cord then enters the inguinal canal through the external inguinal ring. The urethra, the innermost tube of the penis, 7 to 8 inches from bladder to meatus, extends out base of the bladder through a prostate gland into the pelvic floor and through the penile shaft. This is the terminal passageway for both urine and sperm. During ejaculation, sperm travel from the ejaculatory duct through the urethra and out the body. There are 3 glands: the seminal vesicles, prostate gland, and the bulbourethral. These produce and secrete most of the fluid involved in ejaculation and serve as a medium for the transport of sperm. It has an alkaline environment that promotes motility and survival. The prostate gland lies beneath the urinary bladder and surrounds the upper portion of the urethra. The posterior surface of the prostate lies adjacent to anterior rectal wall, and 2 or 3 lobes are palpable through the rectum. The bulbourethral glands on each side of the urethra, just below the prostate, empty directly into the urethra. Here we have a diagram showing both the internal and external structures. The scrotum is a pouch covered with thin, darkly pigmented, rugous skin divided by septum into 2 sacs. Each sac contains a testes and an epididymis, suspended by a spermatic cord, network of nerves, blood vessels, and vas deferens. The testes are suspended outside of the body because sperm production requires a temperature lower than that internal body temperature. Here we just have a diagram showing the inside of those testes and epididymis. The penis serves 2 functions. One, it is the final excretory organ in urination, and it also introduces sperm into its final destination. The body of the penis contains 2 layers of tissue encasing the urethra: the corpora cavernosa and the corpus spongiosum. Erection is the neurovascular reflex caused by increased arterial dilation and decreased venous outflow. This reflex can be induced by psychogenic and local reflex mechanisms, both under control of the autonomic nervous system. Ejaculation is the emission of semen from the vas deferens, the epididymides, the prostate, and the seminal vesicles, and is followed by a constriction of vessels, supplying blood to the corpora cavernosa, and the gradual return of the penis to its relaxed, flaccid state. The rectum and anus are terminal structures of the GI tract. They make up posterior portion of the perineum in males and females. And these structures are usually examined in conjunction with examination of the reproductive system. The proximal end of the rectum lies at the distal end of the sigmoid colon and extends down for 5 inches to the anorectal junction. Called the rectal valves, there are 3 semilunar folds of tissue, the superior, middle, and inferior, that lie within the rectal wall and extend across half circumference of the rectal lumen. The anal canal then extends from the anorectal junction to the anus and is lined with mucous membranes arranged in longitudinal folds called rectal columns, each containing a network of arteries and veins, frequently referred to as internal hemorrhoidal plexus. The perianal glands empty into the anal crypt, a recessed area that lines between columns. The internal and external sphincters, 2 concentric rings of muscle, surround an anal canal. The internal sphincter consists of smooth muscle and is under involuntary control, while the external sphincter consists of skeletal muscle under voluntary control that allows for control of defecation. Here we have a diagram just showing both that internal, external, as well as the sphincter of the anus. When beginning our assessment, we first want to identify any chronic illnesses, as many chronic illnesses may affect both the reproductive functioning in men and women. Also, questions of do you take any medications? What and how often? Especially when dealing with oral contraceptives and broad spectrum antibiotics. These can severely alter the balance of vaginal flora in women. Also, identifying any past reproductive problems. We should identify any previous problems, both with the reproductive system, because information may be helpful when documenting these current problems, or identifying any risk factors for other medical problems. Past surgeries are also going to be an important area to take a look at. Have you had any surgery on reproductive organs or rectum? If so, when, and has it had any effect? Do you have any history of cancers as well? What type? How was it treated? As both men and women may have had surgical procedures to prevent pregnancy, either vasectomies or tubal ligation. A family history is also especially important. For women, has any women in your family ever had a cancer of the cervix, ovary, uterus, breast, or colon? Whereas for men, has any man in your family ever had a cancer of the prostate or testicles? Also, asking about self exams. Do you ever perform self examinations of your genitalia? Assess that self examination behaviors for all patients, as these are especially important for early identification. Also, ask about how often do you have genitalia examination by healthcare professionals? What were the results? For women, they should have a pelvic examination and pap test regularly. Men should have an examination of genitalia and prostate on a regular basis as well, depending on their age. Vaccinations are also going to be very important, especially when we look at things like hepatitis A or B. For females, you should also be have received the HPV vaccine. This vaccine is available and recommended for all females between ages 9 to 26. Also, ask about sexual history or sexual relationships. Prefer relationships with men, women, both, and the type of sex you engage in. All of these are going to provide clues to any areas they may be at heightened risk for. Included in that sexual history will be asking how frequently do they engage in sexual activities. How many sexual partners have you had in the past 3 months? Do you or your partners have multiple partners? And the rationale for this question is to determine the numbers and types of sexual encounters to again identify any areas for heightened risk. Not only asking about that sexual history, but identifying are they doing it safely is going to be another key factor. And for women, asking are you currently using any birth control measures? If so, what type? Do you have any difficulty with the measures? And do you use birth control measures every time you have intercourse? And for women with potential to become pregnant or men with potential to cause pregnancy, should be questioned about both these contraceptive practices. Another question that may yield pertinent results is asking when did their sexual history begin? Drugs and alcohol use could be another clue to identify any potential for high risk activities. And for females, asking when was the first day of your last menstrual period? How often do you have periods? How long do they last? And are they regular? Asking specific questions about the usual amount of flow. Is it light, moderate, heavy? And have they noted any changes in their periods? Also, how old were you when you first started having periods? Men are typically occurs between the ages of 12 and 14 years, although the range could span everywhere from 8 to 16 years. For OB history, have you ever been pregnant? If so, how many times? How many babies have you had successfully? Have you had any history of miscarriages, abortions, or infants who have died before they were born? In this case, gravida refers to the number of pregnancies, while para refers to the number of pregnancies that lasted 20 weeks or longer. Also, asking the patient, do they think they're pregnant now, and have they noticed any symptoms? This can include everything from missed or abnormal periods, or to reports of nausea and vomiting, breast changes, tenderness, or even fatigue. Other questioning may include, have you ever had difficulty becoming pregnant? Have you ever seen a healthcare practitioner for this issue? And what methods have you tried to become pregnant? When looking at a problem based history, this is most commonly reported problems related to the reproductive system and perineum for men and women, include pain, genital lesions, and discharge, as well as problems with urination and rectal bleeding. Just like with all other pain, our good fallback is going to be looking at our acronym OPQRST: onset, provocation, does anything make it better or worse? Quality, describing that pain in their own words, identifying if it radiates anywhere, and the severity on a scale of 1 to 10. For women with unexplained pelvic pain, this should be screened for chlamydia, while rectal discomfort may be associated with everything from poor hygiene, infection, hemorrhoids, or abscess. In men, the pain in the groin or scrotum may occur from problems in the spermatic cord, testicles, prostate gland, or hernia. Testicular pain may occur secondary to almost any problem of testes or epididymis, including epididymitis, orchitis, hydrocele, spermatic cord torsion, and testicular cancer. Other questions related to pain is, do you have any associated symptoms such as discharge or bleeding, abdominal distension, tenderness, or pelvic fullness? Also asking, what have they done to treat the pain and how effective was that treatment? In the case of lesions, identify, when did they first notice that lesion? Where is it located? What does it look like? As lesions or sores on the genitalia can often be caused by STIs or cancer or associated with other problems. Establishing when that lesion was first noticed, as it may be important in identifying the cause. Also, when asking about sexual partners, have you had a sexual relationship with someone who has an STI? If so, when? And have you ever been treated for these infections? Also, identifying, was that treatment successful? In the case of vaginal or penile discharge, again, when did that discharge begin? The color of the discharge? Describe any odor or consistency. For the discharge or change for women may suggest infection. Specific appearances on odor of discharge may also help identify the causative organism. If sexually active, also identify, does your partner have discharge? Have you or your partners had any recent change or additional sex partners? Common causes of penile and vaginal discharge is STIs. In the cases of menstruation, what problems are you experiencing? Have you noticed any clotted blood during your periods? When did this begin? Does anything make it worse? In the case of menorrhagia, this is a term for heavy menses, as clotting can indicate heavy flow or vaginal pooling. Other associated symptoms could be cramps or other pains with their period. Do they occur each month? Does anything relieve the discomfort? And do the cramps or pains interfere with their activities of daily living? Other questioning related to menstruation could be, have you ever spotted between periods? Spotting between periods or mid cycle may indicate that bleeding indicates hormonal imbalance. Other symptoms could be, does this occur with all periods or just occasionally? Does it interfere with your routine activities? And hormonal fluctuation associated with the menstrual cycle may also cause premenstrual syndrome. When assessing menopausal symptoms, when did the menstrual period slow or stop, as well as describing the symptoms they are experiencing? In this case, the term amenorrhea means absent menses. In the case of perimenopausal period for most women, This occurs between most commonly the ages of 42 and 58. Some common symptoms would include everything from hot flashes, excessive sweating, palpitations, vaginal dryness, painful intercourse, changes in sexual desire, and mood swings. Also, are you being treated for symptoms associated with menopause? Are you taking any hormonal replacement? What and how much? Have you noted any side effects? As hormonal replacement therapy may cause fluid retention, breast pain or enlargement, and vaginal bleeding. When assessing erections and erectile dysfunction, assessing when did they first notice problems? Did it develop suddenly or over a long period? Do you have it consistently or does it come and go? As ED is common but delicate topic and can also be highly age dependent. What kind of problem or change with urination are you experiencing? Is it having difficulty urinating? Do you urinate more frequently? Infection is the most common problem in men and women, though urinary obstruction is going to be more and more common with older men, especially as we start dealing with the prostate. Are they experiencing any pain or burning with urination? Is the urine clear or cloudy, discolored, bloody, foul smelling? Other symptoms, such as frequent urination in small amounts, could also cue into clues that it is the prostate. Other issues could be, are they urinating more frequently? Are they awakened at night because they have to urinate? Medications, especially those for cardiovascular problems, diuretics, and antihistamines, may also be the cause behind the increased urination. For men, identify if they have any trouble initiating or maintaining the stream. Does that stream seem narrower or weaker? And afterwards, do you still feel that you have to urinate? Meaning, have they been able to completely empty their bladder? When assessing rectal bleeding, again, when did it first start? Is it constant or does it come and go? Describe any color and the amount of blood, as bleeding from high in the intestinal tract can produce black tarry stools. Other questioning related to rectal bleeding could be accompanying abdominal cramping or pain. Are they feeling constipated, fatigued, and identifying any conditions such as ulcerative colitis that can also cause rectal bleeding accompanied by abdominal cramping? When preparing for a female examination, prepare the room, equipment, a sheet or gown, make sure the room is a warm temperature, and ask for assistance if needed. You should also ask the patient to empty their bladder, undress, and put on the gown. Assist them into the lithotomy position, meaning feet in stirrups, knees apart with adequate draping, the buttocks at the edge of the examination table, and arms at sides or at the side or across the chest. We want to do everything we can to help the patient feel relaxed. If uncomfortable or embarrassed, after she would like her head elevated so that she can also see the examination better. As you start, reassure that you will tell her everything that you're going to do before you actually do it. Also, assure her that if she becomes too uncomfortable, you'll stop and reassess. Inspect the pubic hair and skin over the mom's pubis, as well as the inguinal area for distribution and surface characteristics. You should also inspect and palpate the labia majora, labia minora, and clitoris for any pigmentation and surface characteristics. Furthermore, inspect the urethral meatus, vaginal introitus, and perineum for positioning and surface characteristics. When completing a speculum examination, tell the patient you're going to use a speculum to do an internal exam. Locate the cervix using the middle finger, and place the index and middle fingers inside the vaginal and spread apart about 1 inch. Exert downward pressure to further relax those muscles. And as the downward pressure is exerted, insert the speculum. For a male examination, place the patient in one of two positions, standing or lying down. The patient needs to stand to evaluate for a hernia. They may feel apprehensive about having their genitalia examined. As a nurse, you should be aware of these concerns and approach it in a professional, manner of fact way. Moving on to common conditions and infections you may encounter. The first would be bacterial vaginosis. And this is caused by an alteration of the normal vaginal flora with other bacteria. Typical findings would include things like odorous discharge, vulvar itching, and irritation. Next would be candida or fungal yeast infection. Some women have asymptomatic infections, and they often experience vulvar itching, associated with thick, cheesy white vaginal discharge, vaginal soreness, and external dysuria. Other common infections you may encounter are STIs, everything from chlamydia, gonorrhea, syphilis, trichomonas, to herpes, HPV, or pubic lice or crabs. When it comes to pelvic inflammatory disease, polymicrobial infection of the upper reproductive tract that affects everything from the endometrium, fallopian tubes, ovaries, and the uterine wall. It could potentially lead to infertility, and it's usually caused by untreated gonorrhea or chlamydia. PID could occur as either acute or a chronic disease with a wide variety of symptoms. In acute cases, it's associated with very tender areas, such as over the ovaries and fallopian tubes, and the pain is so severe that the patient cannot tolerate a pelvic examination. Other symptoms include fever, chills, dyspareunia, and abnormal vaginal discharge. In the case of epididymitis, this is an inflammation of the epididymis and vas deferens, usually associated with STIs like trichomatosis or gonorrhea. Clinical findings would include dull, unilateral scrotal pain developing over periods of hours or days. The scrotum becomes erythematous and edematous. Associated symptoms could also include things like fever or even potentially a hydrocele. Moving on to benign reproductive conditions. Premenstrual syndrome. This is a group of recurrent symptoms associated with the menstrual cycle. Clinical findings include a combination of symptoms during the last half of the menstrual cycle and diminishing as menstruation begins. Emotional symptoms, cognitive symptoms, and physical symptoms could manifest. Endometriosis is a benign progressive disease process characterized by the presence of growth of uterine tissue outside of the uterus. Common findings would include everything from pelvic pain, dysmenorrhea, and heavier prolonged menstrual flow. Fibroids are benign uterine tumors that can occur singularly or in multiples that can range in size from microscopic lesions to large tumors. On the other hand, ovarian cysts are benign cystic growths within the ovary that may be solitary or multiple that can occur unilaterally or bilaterally. Most are asymptomatic and often include tenderness and dull sensation or feelings of heaviness within the pelvis. In cases of cervical cancer, this is usually caused by the HPV virus. Clinical findings would be everything from abnormal vaginal bleeding between menstrual periods, after intercourse, or bleeding that is heavier or lasts longer than normal. Endometrial cancer, the most common gynecologic malignancy, occurs most often in postmenopausal women, especially those taking estrogen. Clinical findings would include everything from abnormal uterine bleeding to spotting, although watery vaginal discharge is also frequently noted, several weeks to months prior to bleeding. Ovarian cancer has the highest mortality rate of the gynecologic cancers because it typically goes undetected. Usually, there are no symptoms until it is advanced stages of the disease. Most common symptom is abdominal distension or fullness. By the time the ovarian malignancies are palpable, it is usually well advanced. On the male side of things, testicular torsion is caused by twisting of testicle and spermatic cord, cutting off the blood supply and considered a surgical emergency. Hallmark finding is a history of sudden onset of severe pain and scrotal swelling. In cases of hydrocele, this is an accumulation of fluid in the scrotum. In infants, hydroceles often resolve on their own, but occasionally surgery is required. In adults, the cause is often unknown and may result from infection or malignancies. A spermatocele is a cystic mass occurring within the epididymis, or spermatic cord, filled with sperm and seminal fluid. Clinical findings would be painless, but characterized by a significant testicular edema that is often involving the testicles. On the other hand, a varicocele is caused by abnormal dilation of veins along the spermatic cord. Cause is often multifactorial, as dilation may be caused by differences in venous drainage between the right and left sides. The patient may describe a pulling sensation, dull ache, or perhaps scrotal pain. Testicular cancer is the most common malignancy in men aged 20 to 34. Some findings include painless testicular mass, usually discovered by the patient or his sexual partner. When pain is an initial symptom, usually an indication that the mass has caused bleeding within the testicles or has caused testicular torsion. Moving on to BPH, this is going to be a common condition of older men that involves an enlargement of the prostate. Some degree of BPH will develop in all men of advanced age with minor to moderate symptoms. In cases of prostatitis, this occurs in four recognized categories: either acute bacterial prostatitis, chronic bacterial prostatitis, chronic pelvic pain syndrome, or asymptomatic inflammatory prostatitis. Some clinical findings of prostatitis would include everything from fever, chills, pain in the back, and rectal or perineal area. They may also have obstructive symptoms, hindering urination. The prostate is also the leading site of cancer in men, with approximately 80% of men who reach age 80 having evidence of prostate cancer at autopsy. The pilonidal sinus is a small sinus tract under skin, and lined with the epithelium and hair. When the hair penetrates skin and becomes infected, a pilonidal cyst or abscess results. Moving on to the rectum. Hemorrhoids are dilated veins within the hemorrhoidal plexus that result from increased portal venous pressure. Both genders are affected equally. An anorectal fissure is a tear of the anal mucosa, causing intense pain that occurs in all age groups, but seen most often in young, healthy adults, as the incidence is similar between genders. In cases of rectal polyps, these are protruding growth from the rectal mucosa that may grow outward or may grow adhering to the mucosa itself. Most colorectal cancers arise from these mutated polyps. Rectal and anal cancers occur when a malignant tumor grows within that rectal mucosa, anal canal, or anus. The patient may or may not have symptoms, with the most common symptom being rectal bleeding. A rectal prolapse is a protrusion of rectal wall through the anus. They may occur at any age, though most involve women older than 60 years. In cases of uterine prolapse, this is going to be associated with retroverted uterus that descends down into the vagina. A first-degree prolapse cervix remains within the vagina. A second-degree prolapse cervix is within the introitus, and a third-degree prolapse cervix and vagina drop outside. A cystocele, on the other hand, is a protrusion of urinary bladder against the anterior wall of the vagina. Women may experience sensations of fullness or pressure, stress incontinence, occasional urgency, and feelings of incomplete emptying after voiding. And finally, a rectocele is a hernia-type protrusion of rectum against the posterior wall of the vagina. Clinical findings would range from complaints of a heavy feeling within the vagina to other reported symptoms, including constipation or feelings of incomplete emptying. But anyway, and if you're still with me, that's all we got for this chapter. I'll see you in the next slides.